Hi, everyone. Thank you very much. Sorry for the long title and the long introduction, and I'm happy to get started. So cystic fibrosis, as many of you may know, is a genetic disease which causes an impaired function of the CFTR channel at epithelial cell surfaces, and this ultimately results in a multi-organ disease. This multi-organ disease results in microbial dysbiosis and pathogen selection, chronic airway infection, systemic inflammation, then recurrent reduced lung function, recurrent antibiotic treatments, and not only in the lungs, as many of you may think or know, but also in the gastrointestinal tract. And for a long time, CF care focused on treating symptoms while the disease clock kept ticking. But since around 2020, highly effective CFTR modulator therapies have become available, which dramatically restore the CFTR channel function. As a result, these therapies can slow, and in some cases even turn back, the clock of disease progression in cystic fibrosis. So we set out to answer this question if the clock in the CF pathophysiology is not only turning back for the physiology itself and the host, but also if it has an impact on the CFTR, the microbial dysbiosis and the pathogenic colonization. To answer this question, we designed the IMMProveCF trial, where we could recruit 35 patients at the age from 6 to 35 age of years. And we were able to follow them up until 24 months after the initiation of the ETI treatment. We collected samples every 3 months from throat, sputum, and stool, and also extensive clinical metadata. And we conducted 16S RNA gene sequencing to investigate the microbial colonization throughout the respiratory and the GI tract. So first, on the host side, we saw that the CFTR function increased, shown here as a decrease by sweat chloride, which is a proxy for the CFTR function. Also, we saw an increase in lung function across the cohort over time, a decrease in systemic inflammation, and also a decrease in antibiotic intake. At the sputum microbiome level, we saw a rapid change in the microbial composition and a further stabilization at those later time points as shown here. But most strikingly, we saw that the sputum microbiomes, which were predominantly colonized with staphylococcus at the beginning in about 50% of our cases, that signal was completely lost after the initiation of treatment. Then we further set out to ask what is driving this change and this reduction in staphylococcus. And going through our metadata, we saw that there was a very strong correlation between the staphylococcus reduction and the sweat chloride measurements, so the CFTR function. We then performed nested linear models to see if the sweat chloride is really the driving force. And in the nested linear model approach, this completely overruled the effect, like the time of ETI treatment itself. To further validate those findings, we conducted a mediation analysis where we could demonstrate that 99.8% of the effect of the reduction in staphylococcus was actually due to reduction in the sweat chloride levels. In the gut microbiome, we saw that there was a much slower and less direct response, but still a shift in composition. And in opposite to the respiratory microbiomes, where we saw the stabilization, the gut microbiome was still significantly different at later time point from each other, as shown here. And again, we looked into the clinical metadata to ask the question, okay, what might be the driving forces? And here you can see that Escherichia decreased over time with the treatment taken, but that this, again, in our nested linear model approach, seemed most closely linked to a reduction in fecal calprotectin, which is a marker of intestinal inflammation. So to summarize, we saw improved host physiology, which then had a direct impact on microbiome composition across habitats, where the gut microbiome responded more slowly than the respiratory tract microbiome. And we further also did some direct antibacterial effect testing of the drug itself. And those results, and also some comparisons to healthy controls and a more in-depth cross-habitat analysis, are all summarized in this publication. I linked it here in the QR code if it's of interest to you. And with that, I have to thank, of course, many people that were involved in making the study possible, and the patients that participated, and the funding sources. And I'm very happy to take any questions. Thank you.